Good morning, everyone, and thank you again for the invitation. Really, it's a very controversial issue, and it's very hard really to cover it in 10 minutes. Is there any case for cardiac endarterectomy or CAS for asymptomatic carotid stenosis, which is very controversial. This is a very nice paper published 2016. They look at the natural history of asymptomatic moderate carotid stenosis in the era of medical therapy. And they found the incidence of carotid artery stenosis progression in asymptomatic carotid stenosis still high in spite of using aspirin and statin. Another paper, they look at the patient who come to the hospital with a stroke, and they found 7% of them, they already have carotid stenosis more than 70%, and 46% of they have more than 70% stenosis, even though they were antiplatelets, statin, or both. So what they conclude that medical therapy alone is unlikely to be sufficiently stroke prevention for patients with significant asymptomatic carotid artery stenosis. Another paper, they look at the correlation between asymptomatic carotid artery stenosis and cognitive dysfunction, and they found that ACAS associated with the impaired mobility and cognition that are accompanying with increased fall risk, and these impairment increase with the increased severity of ICA stenosis. So what the guideline? We have two major guidelines. We have the one from Europe, which is the ESVS 2017, and then we have an updated now to 2023. And we have the one from the United States, which is the ESVS, also published recently. If you look at the guideline, ESVS 17 and now 2023 did not change their recommendation regarding asymptomatic carotid artery stenosis. If the stenosis is 60 to 99%, they want us to look at three things. First, the life expectancy should be more than 5 years. If he has a favorable anatomy and one feature, more than one feature suggesting high risk for stroke, then they recommended cardiac endarterectomy or stent. If you don't have them, they prefer to continue with BMT. What the risk factor they are talking about it, if you have epicyclic silent infarction or ultrasound images, if you have a stenosis more than 20% progression, if you have a spontaneous embolization on transcranial Doppler, impaired cerebrovascular reserve, large plaque, and I think Prof. Hisham, he talked about it more in details, equiescent plaque or hypoechoic area, or if you have intra-plaque hemorrhage on MRA or lipid-rich necrotic core. Then we have the recommendation, the new one from the ESVS 2022, published a couple months ago. They depend on two main randomized control trials. We all know about them on the ACAS and ACST. If you look at ACAS study, it's an old study, 1995. We have an updated 2024. It is a prospective randomized trial. They have about 62 patients. They compare medical therapy versus cardiac endarterectomy, and they have 5 years follow-up. What they conclude that CA reduced the risk of stroke or death from 11 to 5%. If you have asymptomatic carotid stenosis more than 60%, with a reduction about 53%. So what they recommend that to do a CAA if the patient less than 80 years old, if you have a combined stroke and mortality rate less than 3%. Then we have an ACST trial from Europe. It's also a randomized controlled trial, 3,120 patients, more than 60% asymptomatic, and they have 5 years follow-up, and they found the same, that CA, that the trial showed that advantage in limiting stroke and death at 5 years for CA combined with maximum medical treatment, 10% versus 4.1%. And you can see that the 5 years reduction was in all stroke and fatal or disabling stroke. It reduced by CA about half comparing with a CA deferred group. Then we have an update on ACS trial called ACS1 trial, where they follow up this patient for 10 years. And even after 10 years, the CA still showed an advantage compared with the medical treatment if patient less than 75 years old, with reduction about 17.9% to 13.3%, with a gain about 4.6%. And half of this reduction was in disabling or fatal stroke. Somebody can argue about all this trial. They did not use any statin. This is very common argument. But if you look at ASCST trial, they showed that stroke risk with CA plus medical treatment was nearly half that with MT treatment alone, irrespective of patient taking or receiving lipid-lowering drugs or not. And you can see that patient, even on lipid, he still, the CA decreased the risk from 1.3 to 0.7. If it's not lipid, it's decreased from 3.3 to 1.8, and both were statistically significant. The other argument about medical treatment, not all patients with asymptomatic carotid stenosis are the same. This is also a very nice paper from Conard. He found that best medical treatment failed to prevent cardiac disease progression about 40% of the patient with ACS and development of epicyclic neurological symptoms in 12%. The second thing, not all patients with ACS are the same risk because depend on morphology of the plaque, and Prof. Hisham talked about it in details. And the last thing, not all symptomatic patients are really asymptomatic because patient, he may get TIAs while he's asleep and he wake up next day morning, he's fine. So we think we still label him as asymptomatic. The second thing, we have now more data associated ACS with cognitive decline. And there's an evidence, it's not very strong evidence, but that cognitive function improve after CA or CAS, whereas no improvement after MT. All this led to the SVS to come with a very strong recommendation 1B, which is low-risk patient, surgical patient with asymptomatic cardiac stenosis more than 70%. They still recommended CAA with best medical therapy over medical therapy alone for long-term prevention of stroke and death. But remember, this is a long-term investment. To get this benefit, patient has to live at least 2 years. So the life expectancy should be at least 3 to 5 years. The second thing, the preoperative stroke rate should be less than 3%. Otherwise, you lose the benefit from CEA. The last thing, they look also the male and female, and they found no difference between male and female. Both they get same benefit from CEA on ACST1 trial. Then we have another trial came recently, a really very nice study from Oxford Vascular Study published also recently. It's a prospective population-based cohort study and systemic review meta-analysis. They correlate between the epicyclic stroke and degree of asymptomatic cardiac stenosis with contemporary best medical therapy in 2,354 patients. And they found that epicyclic stroke at 5 years, patient has 70 to 99%, is 14.6%, whereas almost 0% if you have between 50 to 70%. And this is even better, worse if you have stenosis 80 to 19%, because the stroke rate will be higher than 50 to 80%, which is 18.3 versus 1%. And you can see here's the difference. So what they conclude, the stroke risk was higher depending on the degree of asymptomatic cardiac stenosis, and the benefit of CA was clearly for patients with severe stenosis, more than 70%, especially if he has 80 to 99%. So my recommendation, if it's still in doubt, I'm not convinced that every patient with 70% need to have a surgery. At least use this kind of patient with high risk. This patient will need a surgery. If you have an initial degree of cardiac stenosis, if you have high stenosis like 80 to 99%, if you see progressive of the stenosis on the ultrasound more than 20%, because this will double your stroke rate. If you see asymptomatic embolization on transcranial Doppler ultrasound, ipsilateral silent embolic infarction on CTA or MRA, and if you have a cardiac plaque morphology, if you have an ulceration more than 3, this would increase your stroke rate at 3 years, large plaque area, plaque echolicity, or intraplaque hemorrhage, or reduced cerebral blood flow reserve. The last thing is, should we do cardiac endarterectomy or CAS? We have ACST2 trial. They look at that. They found 3 days rate of death or stroke was higher with CAS compared with CA, but not statistically significant. And they found that this or any fatal or disabling stroke were similar. But the best meta-analysis 2017, they compared ACT1, CREST, EVA3S, ICS, and SAPHIR. All this trial with CA with the CAS, and they found pre-procedure stroke was higher for CAS compared with the CA, but pre-procedure and epicyclic stroke during a long follow-up was the same. And if you look at the composite outcome like death, stroke, or MI were similar. Unfortunately, we don't have any randomized trial comparing CAS with the medical therapy alone. So which patient unlikely to benefit from revascularization? If you have severe comorbidity, because this increases your perioperative stroke rate and death more than 3%, they will not help, they will not get benefit from CAA. Limited life expectancy, less than 3 to 5 years, prior disabling epicyclic stroke or of ICA occlusion. So in conclusion, we think patient more than 70% stenosis should be considered for CA, TCAR, or transcranial CAS, transfemoral CAS to decrease long-term stroke. But again, patients have to have at least 3 to 5 years life expectancy, and your stroke and death rate should be less than 3%. Determination which technique based on the presence or absence of high-risk criteria for CA, TCAR, or transfemoral CAS. Finally, we hope that upcoming randomized trial to answer the role of modern pharmacological treatment measurement of asymptomatic cardiac stenosis like SPACE-2 and CREST-2. I hope I was able to convince you that patients with asymptomatic sometimes need to go for surgery. Thank you very much.